Hi everyone. This week we're going to be assigning AJCC and summary stage for lung cancer. Just two corrections to be made for chapter 36. One is on page 432. The code for minimally invasive adenocarcinoma non-mucinous should be 8256. It states 8250, but need to make it 8256. And then on page 448, a row was omitted from the prognostic stage group table. So just at the end of that table, add NET, NEN, M1 is stage 4. The histologies that are staged using this chapter are listed on page 432. All carcinomas, including non-small cell and small cell, as well as carcinoids, are included. Sarcomas and other rare tumors are not staged using this chapter. As we have learned, clinical classification is essential for selecting and evaluating treatment. To assign the clinical stage, you can use the H&P, all imaging studies, which may include CT, PET scan, or PET-CT. However, these are not required to clinically stage the cancer. There's also lab tests and staging procedures. Most of the lung staging procedures that can be performed are listed here on this slide and are also listed in your book. The type of procedure used to obtain pathological confirmation of lung cancer differs depending on the location of the tumor and the spread of that tumor. Invasive staging procedures are not indicated for patients with extensive mediastinal invasion or stage 1A tumors less than 3 centimeters in size that have no suspicion of mediastinal lymph node involvement on CT or PET scan. As listed on the previous slide, there are many imaging techniques and invasive procedures that may be used to diagnose and stage lung cancer. Whenever possible, these should be performed sequentially and with an increasing degree of invasiveness. The IASLC recommends the use of a 3-step protocol to rationalize the use of staging procedures. Step 1, history and physical examination, as well as plain radiograph of the chest or X-ray, and blood tests. Step 2 would be complex investigations. That would include contrast-enhanced CT, bone scan, PET scan, brain CT, and bronchoscopy. Step 3, more invasive procedures such as surgical exploration of the mediastinum, the pleural space, or the pericardium, using the methods listed on the previous slide. A CT scan is important for assessing the size and location of the tumor and to see if any enlarged mediastinal lymph nodes are present, because in the absence of metastasis, these are the strongest indicators of prognosis, so the information is very important. A PET scan is indicated in patients with no clinical abnormalities and no signs of metastatic disease on CT who are candidates for treatment with curative intent. It is useful for the evaluation of metastatic spread, except for brain mets. MRI are very specific indications in lung cancer staging. MRI of the brain is indicated in patients with stage 3 and 4 tumors, even if they have a negative clinical evaluation. It is also indicated for patients that are diagnosed with brain mets by a CT scan. An MRI may identify additional lesions that are not seen on the CT. When you read an imaging report, the radiologist may use terms such as lung nodule or a lung mass. The difference between a lung nodule and a mass is that a nodule is less than or equal to 3 centimeters in size, and a mass is greater than 3 centimeters in size. So that's why you might see the different terminology used because of the size of the tumor. The pathological classification is used to guide adjuvant therapy and provides useful information to estimate prognosis and calculate end results. It is based on all clinical information and additional information acquired from surgery that the surgeon will document in the op report and the examination of the resected specimens by the pathologist. The requirements to assign pathological stage for lung cancer is to have a resection of the primary tumor or a biopsy proving a T4 lesion and the removal of enough lymph nodes to validate the absence of lymph node metastases or that evaluates the highest PN category. It is recommended that 6 lymph nodes be removed. These lymph nodes should be both hilar and mediastinal lymph nodes. It is accepted that if there are less than 6 lymph nodes removed and examined, that you can assign the classification as PN0 if the lymph nodes examined are negative and the primary tumor is completely resected. This chapter talks about the definition of the visceral pleural invasion. I will not go into that here since Dr. Bitar went over that in his presentation. Classification of lung cancer with multiple lesions poses some problems in the past because the rules were sometimes ambiguous and they could be interpreted differently in each situation. In the 7th edition, there was only one paragraph that guided the physicians in how to handle these situations. And as stated, they were not necessarily interpreted consistently. For these situations, cancer registrars always use the solid tumor rules to determine if one or more abstracts should be completed. So to rectify this situation, a special subcommittee was formed to look into this situation. The subcommittee established that there are 4 disease patterns, and with these patterns, they developed clinical and pathological criteria for each of the disease patterns. The chapter goes into these disease patterns in detail, and there are tables listing the clinical and pathological criteria for each disease pattern. For right now, since these are not the most common cases that are encountered, we will not go into this information in detail. We will just stick with the easy cases for this semester. But you should keep the following information in mind for now. The 4 disease patterns that the subcommittee described for multiple lesions are 1, second primary tumors, 2, lung cancers with separate tumor nodules of the same histopathological type, multiple tumors with predominant ground glass features on CT and lipidic pattern on pathological examination. Dr. Bitar does talk about these in his presentation, so you will get more information on that. And then the 4th one is diffuse pneumonic type adenocarcinoma. So for right now, you don't need to know that. We won't have to worry about that type of information for our cases this week. Assigning the site code for lung cancer using the ICD-10 manual is usually pretty black and white, except when it comes to lung cancers with hilar masses. The ICD-10 code C34.0 is assigned for multiple sites of the lung: the main bronchus, the carina, and the hilus of the lung. Now, there is something that we need to remember when it comes to the lung anatomy. The hilum is actually a space. It is not part of the lung itself. This space holds the nerves, lymph nodes, and blood vessels for the lung. So if there is a hilar or hilus mass, it could be an extension from the lung parenchyma, or it could be a mass made up of regional lymph nodes. So how do we code a situation when the patient has a hilar mass? If you have a hilus or hilar mass and the mass is not stated as adenopathy, then we can code the tumor site to the hilum or hilus of the lung C34.0. If the hilus mass is described as adenopathy, then we use that information when we assign the N category to at least N1 or involved hilar lymph nodes. If the hilar mass is adenopathy, then it is not the primary lung tumor. I'll repeat that. If the hilar mass is adenopathy, then it is not the primary lung tumor. It is just lung cancer that has metastasized to those lymph nodes. Another thing to keep in mind when assigning site code: if there is an infrahilar or suprahilar mass, that is assigned to the site code 34.9, since this could be a mass in the upper or the lower lung lobes. This is not specific enough information to assign a specific lung lobe. Hopefully the patient will have additional imaging or surgery, and they'll be able to determine the exact site. But if that's all the information you have to assign a C34.9. As a reminder, the right lung has 3 lobes and the left lung has 2 lobes. It should be noted that the bottom of the upper left lung lobe goes all the way to the bottom of the lung itself, and the lower lobe is greater than halfway up the upper lobe. So it is very important to know that if the radiologist does not state which lobe the tumor is in, that we do not assume that it is in the upper or lower lobe by the landmark that the radiologist may use. This is the illustration of the outer layers of the lung, which I shared with you a couple weeks ago when we were working on the lung SSDIs. Once again, note that the parietal pleura is the outside of the lung organ, while the visceral pleura is part of the lung itself. So it is on the inside layers. And then the pleural space is between these 2 layers, and this is where a pleural effusion accumulates. This colored illustration is from your book, the AJCC book. Unfortunately, this one does not have the layers labeled, but you could label them using the labeled one as a reference and put that in your book if you would like to have that information in your book. So here are the T categories. And for the first portion of the T categories, the T1, it's by size. Then we have T2 with subcategories, and then T3 and T4. We'll get into the T2 umbrella category in a little bit because the T2 category and subcategories is a little different for the lung and how they wrote the table. So we'll discuss that when we do one of our cases. Then we have the N categories. And for the N category, it's determined by which lymph nodes are positive. Are the hilar nodes positive? Are the mediastinal or subcarinal nodes positive? Are contralateral mediastinal or hilar or ipsilateral or contralateral scalene or supraclavicular lymph nodes? So as you can see, it matters for which lymph nodes are positive when assigning the N category. There are several illustrations of the lungs' regional lymph node stations in the manual, and this is another one for you to reference. For the superior mediastinal lymph nodes, surgeons will usually label them lymph nodes 2R, 2L, F, 4R, or 4L. So this is a nice little reference to use just in case they're using their numerical letter codes instead of stating exactly which lymph nodes they're talking about. You may see the word lymphadenopathy on imaging. Now, AJCC does not have rules assuming lymphadenopathy is malignant, where summary stage does for lung cancer. But keep in mind, if a lymph node is greater than 1 centimeter in the short axis by CT scan, that's the verbiage they'll use in the radiology report, it is considered abnormal and suggests metastatic involvement or positive for cancer in the lymph nodes. If the radiologist does not state that the lymph node or lymph nodes are positive or consistent with metastatic disease, but there are further indications, tests, or managing physician states these lymph nodes are involved and or positive, then we can consider these lymph nodes positive clinically, all right? Sometimes the managing physician and radiologist will reread the imaging together, and they may decide between the two of them that, yeah, these are suspicious for, metastatic disease. However, that report doesn't necessarily end up being updated with that information. But if the medical oncologist, radiation oncologist states something, in their notes that they're considering this lymphadenopathy or enlarged lymph nodes positive, then we can assign them as positive. But do keep in mind there are reasons other than lung cancer that lymph nodes can be abnormal or enlarged. So we should not assume they are positive unless stated by the radiologist or another physician. Then we have the M category, M0, and then M1 subcategories. Make sure that if you do have distant metastases, that you go to the subcategories and assign one of those instead of just using the M1 category. This is the illustration of what a pleural effusion looks like on imaging. Per AJCC guidelines, we assume an effusion is malignant unless there were negative cytology results on multiple specimens. It is non-bloody, not an exudate. And they'll describe that in the report. So you'll see those words exactly when they do the procedure or when they look at the specimen itself. And clinical judgment correlates with a benign diagnosis for the pleural effusion. For example, congestive heart failure, pneumonia, pulmonary embolus, kidney failure, and lupus, to name a few of the diseases that can cause a pleural effusion, and meaning it's not a malignant pleural effusion. But unless the patient has one or more of those things, we would assume that the patient's pleural effusion is malignant. There are no prognostic factors required to assign the lung stage group. So one of the easier prognostic stage groups to assign. Just want to quickly note that the lung chapter states that pathologists should use the 4-grade system as listed here. So this grading system supersedes any other grading system that the pathologists may use. Remember, they are guided by CAP to use this grading system, and hopefully they do. A quick review of the summary stage for lung cancer. Summary stage 0 for in situ or non-invasive cancers. This does not happen often in lung cancer. Most people are diagnosed at a more advanced stage. Summary stage 1 is a lung cancer that is localized and confined to the lung and or main stem bronchus. Summary stage 2, regional by direct extension only, is when the tumor has grown beyond the lung and into these structures that are listed here, or when there are multiple lung masses or nodules in the same lung lobe or main stem bronchus as the primary tumor. So now with the lung, because we have lungs that have multiple lobes, there's the regional by direct extension has a lot more ways in which it can present as regional by direct extension only. So pay close attention to those things that are quite different with lung staging. Summary stage 3, only the regional lymph nodes are involved. Note the word ipsilateral lymph nodes for regional lymph nodes involved only. The positive or involved lymph nodes must be regional lymph nodes on the same side as the primary tumor. The regional lymph nodes for lung cancer are listed there. All other lymph nodes would be considered distant lymph nodes. So if a lymph node isn't listed here, then you can assume it's a distant lymph node and assign the summary stage accordingly. Summary stage 7 includes distant lymph nodes, which some of them are listed here, but not all of them. Any contralateral regional lymph nodes are considered summary stage 7. This includes hilar and mediastinal lymph nodes. Separate tumor nodules in the same lung but different lobe is considered summary stage 7. Separate tumors in the contralateral or other lung not involved by the primary tumor is also considered summary stage 7. So there are 3 cases for you to practice on. So stop here, do the 3 cases, and then come back and watch part 2 of the presentation, and we'll go through them together. See you then.